Okay, so hello everybody, good morning. It's emergency medical training unit teaching, am I right? Thursday, what the date is today? The 2nd of December. We chose this topic, decision making, process, because we always use this process every day, every time, in all of our life, whether at work or outside work. Okay. But here we are particularly talking about, at our work. Now, I think specialty learning outcome, we could go in the management, we could go in a general set of, as we mentioned, non-specific set of application of clinical knowledge or something like that, so whatever we SLO select, I think it will fit there. Now, what's the definition of a decision? That's again very important from the medical legal point of view as well. So the definition of decision, is a conclusion or resolution after consideration. Now I'm putting stress on word consideration. So by which we mean that decision can't come out of the sky. Okay. So some sort of consideration is behind the decision, hence the definition of the decision. I think the as we talk about this one, so we also need a definition of evidence-based medicine, because that's also very important in this decision-making process. And then we talk about what sort of terminology we use, common terminology at our workplace. And of course, then we talk about what goes behind the decision-making process, and then different types of decision. And then I think, to me, the very important topic will be at the end, the biases which are in the decision-making process, because if we are aware of them biases, then the decision-making process, get better and impartial and effective. So hence the biases which we talk about at the end, which are a few. I'm sure we know about all this stuff. I'm pretty sure it's not new to us. Okay. The only thing is, my main aim is, because you are at the course of becoming a senior doctor, leader of the ED, consultant in ED. So my main aim is that we should be aware of that something exists out there, which is a decision making. So don't expect from me like a very scholarly article or statistical article, not at all. I'm not a professor, I'm not a teacher, I'm just a clinician. Okay. Hence I will be simple, straightforward, very common, and when I will talk about stuff, you might already know about that. Okay. So that's the beauty of that set of talk. Okay, so we define decision and we stress on the consideration. And evidence-based medicine, again, the definition we are talking about, they're very important in your career, in the interview. What will we talk? Whatever I will talk, believe me, that will take you through to interviews process as well. So evidence-based medicine has got 3 components. Okay, one is the best available knowledge, procedure, process, medication out there. Okay. The first component. The second component is it is applied expertly, in an expert way, by a trained professional or a doctor or somebody. Okay. Now the third component is very important to me. Okay. It is applied by a profession, by yourself, by myself, by any other professional, which fit the patient norms and the lifestyle. So again, to me, believe me, the third component is most important. And we know only, 10% thing we do, which are really have a strong evidence they work. I mean, 90% of the time we are, I don't know what the word we should use. You know what I mean? So we know by the research. And I think I think Boone and Dr. Zia, because they're senior doctor here, they will know what I'm talking about. So hence the third component is very important, that which fit the patient norms and the lifestyle. Okay, and we will, so this is just to keep this sort of definition in your head, because when we proceed a bit further, so I think, you will understand why we start at the beginning of this talk with these sort of definitions. Okay. Now, the next slide would be, how can I go to the next? Okay. The CNN our work. Okay. So I've used common sort of terminology, which we use all the time. Okay. Now, I mean, we ask each other, okay, Boone come to me, Ja come to me, I come to you yourself. You say, Mr. Junjua, what's the plan about this patient? Okay. In fact, we will be asking, what is your decision about this patient? Now, this word, when I still think about what is the plan about this word, I still start laughing. Believe me, 5 years ago, if somebody will ask somebody, what's the plan? What is your plan? He used to feel threatened, okay, challenged. So, but I used to tell people, no, we keep on asking this question to the people, because if we won't start asking this question to the people, because of the people feeling threatened or challenged, then things won't straighten up, okay. Now, I still remember, because this challenging, this is one of the qualities of the leader. Leader challenge the process, okay. So if you're a leader of a team, of an environment, okay, so this question need to be asked, but we must ask in a way which does not seem to be threatening to people, okay. So this is one part of the aspect. We daily talk about our workplace, what the plan of this patient is, okay, because without plan, without decision, I might have a big plan in my head, but if I won't communicate with the team through writing or through verbal, so nothing will happen. Okay, so that's the common thing we use in our workplace, hence the importance of the talk we're talking about. Shared decision, again, is a buzzword, is a common, is a practical, and it encompasses the third part of the evidence-based medicine. Okay. Now, we know what shared decision is. Shared decision is a decision which is made, in consent with the patients or the people whose life is being impacted upon by my decision, your decision, or anybody's decision. So involving people into the decision is very important. I can give 100 reasons why it's important. Okay. So for instance, one is, if you want to prescribe some antibiotics or some medicine, or fruitamide, whatever, and you don't tell people, believe me, the evidence shows that people don't take it. Okay. And I can tell you long stories. Once, we admitted a patient in our CDU. Okay. The person next to that gentleman, he was an elderly gentleman, was on methadone. He was admitted due to head injury. Okay, because I know the situation. Early in the morning, they discharged this elderly gentleman. He picked the methadone bottle, take home. Okay, and he went to the neighbor. He said, "Oh, how should I take?" He said, "You have to take 50 mils. I don't know, twice daily, something." So he was found dead. Okay. Now, shared decision making. I mean, this is an extreme example, but it happens. So very important shared decision making. Because of the compliant, if we won't tell people, they won't comply to your treatment. And again, a shared decision-making process is important to take into account this effect of your treatment on the psychosocial life of the patient. These are words out there which we are commonly used now, and so which we must take into account the third parties consideration as well. Innovation, I mean, again, decision making and innovation, they have got a quite important link with each other. And innovation is very important in our working life, because if you're a leader, okay, and we lack the process of innovation, so what's the difference then? You know what I mean? What's the difference between, a consultant and, you know, anybody else there? Because that's very important quality of our leadership and the decision-making process. Now, uh, innovation is, for instance, if somebody, I will take this one into innovation as well. For instance, if somebody asks you, okay, what should I do about this wound? Can I stitch it, the wound? Okay, now you are busy. Okay, when you're busy, so you think of some innovation, you say, no, it doesn't need stitching. It can be mended in that way as well, an alternative way. So again, this is a decision which has impacted upon the practice. Delegation, should I go faster? Guys, should I go faster, or can I explain everything? Time-wise.
To you, boss.
Time-wise, we are okay?
Yeah.
Okay.
We have up to 10 o'clock, isn't it? So it depends on, I don't know how many slides you have.
Oh, no. I think, what's the time now? No, I don't want you to get bored as well.
No.
So that's very important as well. So again, innovation is also important. As I give an example, the wound management, the fracture management, because one clinical condition have got a lot of option to manage. It's not just one. It's not just the one option. I mean, aortic aneurysm now have got an option. Okay, you don't do nothing. You do repair it after opening up the abdomen, or you repair endovascularly, or you put a stent in. You know what I mean? So there are a lot of options. So that's also is an innovation, because a clinician think of different options of a condition. Delegation is again very important in a decision-making process. For instance, you are busy, okay, there's a shoulder dislocation, and you've got less number of staff. Okay, so my take would be there's no point you to struggle there, because if you start manipulation of something like that, which can be done by somebody else, which have got a less impact on your business at the time. So why don't you delegate? Get orthopedics. You see what I mean? So delegation is also a very important decision in our workplace. Okay. Again, when we are in definitive care, again, this is a decision. So when to arrange definitive care, what to arrange, where, or by whom, whether it's in the hospital or in Northern General or in Royal Hallamshire or in Leeds or Sheffield, wherever. So definitive care arrangement, again, is very important. Because I also included medical education and training. Very important, because when you are a trainer, when you are a, educator, as Boone is experienced, Java's previously, the people like that. You see what I mean? So you see how many decisions have to make. So in every part of the life, we make our decisions, similar management and meeting stuff, So again, there are a lot of decisions to be made, job planning, rota coordination, how to talk to your senior manager in front of the board, what to tell, what not to tell, how to tell. So every aspect of a life is a decision-making process. Okay. Now, factor involved into the decision. The slides are a bit relevant, because it's a time constraint. Otherwise, I can make each and every word relevant to the talk, because, I think I might skip something. So I must say that. So I think we talk about important things. So in any decision, so there are three things involved, which is people, resources, and environment. Okay. So decision is not just a one thing. A lot of stakeholders comes into it. Okay. Believe me, I've seen people in our consultant meeting team now, because I don't hide anything. We have got a discussion on the rota. Okay. You know what? People think, no, it's me who is unfair. things are unfair only to me, but they don't think there are a lot of other stakeholders involved in. Okay, because when in your life, it's not just you. You've got a lot of other stakeholders. You got your family, you got your children, you got your parents, you got your society at the work, you got patient, you got hospital. Okay, so a lot of other stakeholders are there. You got a taxpayer, you got a people who pay you. So hence decision-making process is a complex process, and the people who succeed, believe me, they take all this thing into account. So people, resources, and environment. And when we talk about people, then people are the people. They've got their personality, and we know the managers spend a lot of money and a lot of time on typing the personality, type A, B, C, D, 3V, yellow, green, blue, colors of the personality. So they have got a personality. And in fact, scientifically it's proved that these, profiling are good. So they've got their cognition, they've got behavior as well. So when we go with further talks, so these will be quite obvious in that sort of stuff. When we talk about resources, so we talk about money, material, and objects. Okay. And when we go a bit further, we will allude to example in our work. So, what we mean about that. And environment is also including capacity and structures, of course, climate as well. For instance, if, we give a bit more example. I mean, the emergency medicine in the field. So, so the CN will be impacted upon by the climate. You know what I mean? So we could give a lot of example. For instance, if somebody's leg has been amputated, okay, and the case go to coroner of the court, so so these are things you need to consider that. So why the CN was reached at that time because of these factors, and those factors will be absolutely admissible in the court of law. So cognition, of course, time link everything. Okay, time link people, resources, and environment. Time is the essence. Time is the boss. Okay, and we know there are time critical condition, which we will allude a bit further, where the scene is reached without doing something else, which we do are essential to do in normal sort of situation. Of course, when you take the scene, you think of team working, you think of skill mixed. Okay, but guys, what should not happen is the emotional involvement. Okay, we are the coolest people on the world, on the planet. Okay, common people think, other people think, no, we are ED people, we are emergency people, we are always on our tiptoes. Okay, so we are rushing around, we're jumping and doing all sort of funny sort of magical stuff. No, we are the coolest people. Our job is to cool people emotionally and physically. Okay, so that's our job. Main job is that one. Of course, we employ tools. I mean, application of tool. If I know how to build a wall, I can go to a B&Q and get some, what they call them, things where you put cement on and stuff. I can build a wall. So tools are not important, is the capacity to use that. Okay, so we are the cool people, and we should not be involving our emotion into this sort of stuff. Okay. Now, I know the art of these little pictures because they are on my computer. I just copy paste them. This one with the two, what they call them, circle in the head. Okay, so different types of decision. There are huge types of decision. Okay, but I research and put only things which are concerning to us. Okay. Now, I must say before going into that we are, the doctors, especially in A&E, I'm not biased because I know that's how it is. I know my life, how many things I've done before reaching to this stage. So working in ED is a very complex. Okay. Of course, we don't operate. Of course, we don't do PCI. Okay. Of course, we don't do endoscopy. Okay, of course, we don't thrombolize for the stroke. Of course, we don't treat schizophrenia. We don't do electroconvulsive therapy. Okay, but in fact, we know each and everything. Okay, are we supposed to know each and everything? Okay, we are the what they call trade of Jack and master of none. So that's how it is. Very difficult, especially these sort of things which we're talking about. We use them a lot, and we use a lot of things to make them decision. Lot of process, lot of factors. So really is a complex situation which we deal, but our head is trained to do that. Okay, hence we don't feel it. Okay, because in Coverdale, these people, specialist people, used to joke about us. Oh, you are a triage service. So we started giving them the locum. Believe me, after doing a couple of locum, we used to pay them handsome money. After about doing a couple of locum, they said, no, we can't work anymore. Thanks very much. Then they start respecting us, believe me. So it's very, very things, very important things we use, and a lot of things we use, but we don't feel it because our mind is trained to that. Okay, so these are different type of decision-making process: rational, pattern recognition, process of analysis, and process of intuition. Okay, now let's talk about, I think we use mostly the upper two. That's the most commonly we use it. Okay, rational decision-making process. I mean, this is just simply bit of characteristics used: no knowledge and judgment, fast, short term, how to talk, low tolerance of ambiguity, and decide something like that. I think in here I must say, I skip a couple of things here. So a couple of definition. So what is the low tolerance of ambiguity? So this is the okay. Now the tolerance of ambiguity mean, low tolerance of ambiguity mean that the is like opposite. High tolerance mean that I don't care about other factors, okay, because I start doing decision making process and take into account the factor which affect the decision as I go along. You understand? That's the low tolerance. No, that's the high tolerance of ambiguity, because I start making decision, for instance, and as the new factor comes in, so I take into account those factors into my decision-making process. So two things go hand in hand. Low tolerance of ambiguity mean that I think of the factor affecting the decision before going to next step. Understand the definition? So high tolerance of ambiguity mean that I take the factor into account as I go along. So they are parallel process. The low tolerance of ambiguity mean that I first think of the factors and then I take the next step. Okay, so that's what I mean. Other thing is democratic sort of mind and the social focus. That's the another two term we need to know about that. Democratic mean that when a decision maker make a decision, its main consideration is impact on the life of people, okay, and also the involvement of the people in the decision making process, okay. And the social again is a behavioral stuff, because when the decision maker process have got a social overlay, then what happens? They take into account the opinion of the team member. So the team member, they heavily involve the team members in. So this is meaning by these four sort of terminology, which will be coming along as we will proceed a bit further. Okay. So the rational is, so while you make, we use economic, what they call acronym decide. Okay. So decide mean, now we will know how we use it. We first define the problem. Okay. What the problem is. For instance, now people come to me, they ask, oh, can I do a CT scan on a person? Okay. I said, why? Because that person is on warfarin. Okay. Why you want to do CT scan? Because they're coming with a fall. Okay. Oh, any head injury? No. Any swelling or bruising to the head? No. Then I ask, why we do the CT scan? Okay. You can't justify doing a CT scan on a person who has just come with a simple fall, did not bang the head, and there's no neurology, no swelling, bruising to the head, because it's on the warfarin. Okay. You see what I mean? So we first had to define a problem, whether the problem exists. If the problem exists, so then we proceed the next step. Okay. So the first thing is you define the problem, and then, so what you do, you identify the criteria. Okay. So identify the criteria. What criteria we identify is, so we identify, okay, we have to further evaluate this problem by history, examination, and arranging investigation. Okay. So then, after application and identifying the criteria, then we consider alternative, mean differential diagnosis. Okay. So after considering a differential diagnosis, then we decide what is the best alternative. Okay. Now, best alternative can be, in medical terminology, we say working diagnosis. Okay. For instance, if somebody come with the abdo pain, okay, so the pain is, shooting from the back to the front, okay, abdomen is soft, and he's hypotensive, he's got lipid tachycardia, okay. So the working diagnosis here, we all know, is 55, 60 plus. We all know that our working diagnosis will be aortic aneurysm under proof otherwise, okay. Even, then you rush for the fast scanning, whatever. Yeah, that's what we mean the working diagnosis, because, the diagnosis which you can work with further. Okay, so that's what we mean. That's how we select it. And then we develop and implement the action plan. Okay, so for instance, we treat people, we discharge people, we admit people, okay, or we, refer people in the hospital, outside the hospital, okay. The final step is we also keep on evaluation and reassessment, whatever the treatment we have initiated. Okay. If we have put a drip up to raise blood pressure, so we can't keep on giving fluid, so we need to assess at the end of our step taken. Okay. And we feedback as well. We feedback to our patient, to doctors, to nurses, to family. That's what we've done. Okay. That's what needs to be done. You see what I mean? So that means rational decision making. Okay, so we follow a set criterion there and decided the acronym which we follow. So define problem, identify criteria, then you think of alternatives, select the best of them, then make an action plan and put in place, and then continuously evaluating and stuff like that. And that's we do by history, examination, investigation, making a working diagnosis, putting an action plan, evaluation. Okay, so that's we use commonly, we use it. We might not know it. We are using, as I spoke earlier in opening of the conversation. Okay, so that's what we mean by the rational decision-making process. Any questions so far?
Hi, Mr. J.
Mm-hmm.
So how can I make for rational for basically I'm talking about the last night shift. So I was on soft floor study, and I've seen two patients.
Mm-hmm.
One of them is coming with she was 78 or 79. So
Mm-hmm.
she's coming with sudden onset of left upper back pain. So, and she was on Epixaban because she has got AF and pacemaker as well. So I was supposed, and then I did like the blood's inflammatory marker was raised, chest X-ray looks okay, ECG was fine, trop is okay. So basically, I know something is wrong with this patient.
Yeah, yeah.
So basically, I was not able to make a decision whether I can go for the like CTP or not. Then I asked to add the like D-dimer, but they're not happy to do D-dimer because the trust policy is if somebody's on blood thinner, so they are not doing the D-dimer. The first thing. So anyhow, I know something is wrong with this patient, so I lied and requested like CTPA, and CTPA was reported like multiple thrombus.
Well done. Absolutely.
With right heart strain, first case. And so at the moment, I can't give like proper rationale for the CT scan. But there was something wrong with the patient.
Okay,
so this was the first patient.
No.
This was first. I have seen second patient as well. She is 35 years old, coming with severe sudden onset of right upper back pain, radiating to front. And she was obese, around her weight was like 116 kg. So basically I did like blood all okay, ECG was okay, chest X-ray was okay, and still patient having pain. But after the 1 gram of paracetamol, the pain was a bit subsided. Everything was look okay, and I was not able to make a decision whether do I need, because he was young, and whether I can go for the CTP or not. Then like I talked to the one of the registrar, Adnan. So he told me like, boss, go for the CTPA. Something is wrong with this patient as well. So I requested CTPA, and CTPA was reported like multiple thrombus, right lung with right heart strain. So in the both cases, I was not able to give proper rationale for the CT scan.
Now I think the things you're talking about, that's a rational in English language meaning rational. Okay. But here rational is not that meaning. No. Rational is what we're talking about. Now you use decide model, you define the problem, okay, you talk the history, you do examination, you put investigation, okay. So you at the level of the working diagnosis, you are not sure what's happening, okay.
Exactly.
Then you proceed further and you went for investigation which proved that they have got a problem. Now the decision-making process is not just a rational, there are other components as well, and when we finish the talk, you will absolutely come to know that what method you were using, okay. So as I said earlier on at the beginning of the conversation, that we use a lot of stuff while we decide. We use sometimes a bit of something and a bit of something else. So it's not essential that we be using like exact model, because the mind switch from one to another. Okay, it's very important. The mind switch to one to another. So this thing is very important to keep in the mind. Okay.
Yes, thank you, Mr. Thank you.
You are absolutely right. So you have done the right thing. When we proceed a bit further, you will know how many models you are using. That's the beauty of our trained mind in ED. Okay, because we use a bit of everything, quite frankly. Okay.
Yeah.
So this rational is different. Rational is what we are talking about. It's not the sense of English meaning. Okay. So let's understand. Happy with that? Because this is a terminology, a technical word, rational, in the sense of our conversation. Okay, so the next is a pattern recognition. We use this one a lot. Okay. Now, again, I've written, pattern in a clinical recognition of pattern scenario and a pattern in a scenario, run through a course of action, pros and cons, and then you come up with working diagnosis. Okay, so I can explain pattern recognition clinically. So how we use this one. But I must say,
sorry, Mr. J, can I interrupt you a little bit?
Please do.
This is Suraj, first time studying.
Hi, Suraj. Yeah.
Hello. I just heard about this term low tolerance of ambiguity, and I was actually searching in the internet as well. So does that mean you rush to the judgment very soon based on what the circumstances you are in?
No, not at all. Because this is the thing which we use. Okay. Now, we don't talk about rushing here or slowing here. Not at all. So we use that sort of way of thinking to reach our decision. Different people use in a different way. They both are right. So we are not here, discriminating right or wrong or saying right or not at all. We are here talking that some people have a low tolerance of ambiguity as a personality, and some people have a high tolerance of ambiguity as a personality. And equally, because we are a human, okay, we switch across as well, depending on the situation. Okay.
Right.
So that's the beauty of that sort of talk, is it? Decision making. We are flexible. Flexibility is very important in a leader, very important, because if the leader is rigid, so the decision will be wrong. We have seen them at a world stage. We have seen them at a working stage as well. The more the flexibility people show, the more good is the decision. Because flexibility and the tolerance, that will be reflected into listening to the people. Okay, because the decisions have impact on the people's life, and we take into account the people when we decide. So flexibility, listening, ambiguity, low, high tolerance. So this should not be fixed. It should be transferable. It should be flexible.
Right. So you actually mean to focus on tolerance of ambiguity rather than the low tolerance?
No, you are absolutely right. So these are the terminology which we use, because there's no other way that I can explain. So low tolerance means sometimes I make a decision. So I say, no. Oh, first, take this factor into account, depending on the decision. For instance, if I'm a nuclear button, I'm just giving an example. Okay, so before pressing the nuclear button, people will think a lot. You see what I mean? Similarly, if I'm a surgeon, before opening the tummy up, believe me, I've done this thing. I used to sit together and ponder on it. Oh God, what I should be doing before giving an incision. Okay, and what I will be doing once I encounter a ruptured appendix, or something nasty, or bleed or something. You know what I mean? So that's mean the people sit down, they think on the consequence, and then they take a next step.
Sure, I got your point. Thank you. You carry on, please.
Thank you, Suraj. Thank you. Okay, pattern recognition. So we use it a lot in our working day. I can give you an example, but before giving an example, I will tell you some condition. If we know about that, their pattern is such that we don't need to, arrange any investigation. The diagnosis is there. Okay. For instance, ruptured Achilles tendon. Okay. So the pattern is, oh, doctor, I was walking. I thought somebody kicked me on my heel. Then I am not able to walk. It's very painful. Okay. And then you see the Simon test. Okay. There's no movement of foot and squeeze of the calf muscle. And then you palpate your finger. There's a gap there at the tendon. Okay. Now, previously, believe me, that's the diagnosis we used to reach. But now some orthopods say, oh, can you do an X-ray? Why? Because there might be a Avelian fracture. You see what I mean? Because orthopod don't want X-ray for anything. So similarly, when there was no X-ray, or even still in the part of the world where there's no X-ray or not much facility for investigation, bowel obstruction, if people are coming with cold abdominal pain, vomiting, distension, constipation, tummy is quite tender. Some part of the world, they don't do investigation, they just open it up. Okay. Similarly, asthma, cough, wheeze, short of breath, and is not persisting. So it's a paroxysmal episode of cough, wheeze, chest tightness, and short of breath. So we diagnose asthma. Okay, because these tests are invented and came now, the peak flow, the lung function test, whatever. And in some communities, we don't have these sort of things. Okay, because I worked in that sort of environment in my early days. I'm pretty sure, some of you guys might have worked in that sort of environment. Okay, so that's what the pattern recognition is. So similarly here, we recognize the pattern, then we confirm it with the investigation. So you see what I mean? So we are switching from a pattern to rational to pattern. You understand now? Because they're not compartmentalized, they're not conclusive or exclusive. They are inclusive. So you recognize a pattern, you say it must be asthma. So then you go with a rational, how you confirm it. You take history, examination, establish alternative. You know what I mean? So the more things you use, the more safe clinician you become. Okay. So understand the pattern recognition. So basically, it's recognizing a pattern of a disease presentation. Okay, should we proceed further?
Yeah.
Okay.
Yeah.
The next is a process of analysis. Okay, so we use analysis to make a decision. Okay, so again, it has to be flexible. It has to be a step by step. So we make a question. Okay, then either it's a yes or no. Okay, and here we can use yes as a permission to proceed further, or we could yes no to as a permission to proceed further. So this is not a clear cut like a objective set of isolate thing, by which I mean it's not like if it's a yes, then you have to go to next step. Okay, and if it's no, then you stop there. Not at all. Flexibility. So sometimes it's a yes to a question, then we proceed further. And sometimes it's a no to a question, then we proceed further. And sometimes we use both no and yes. Think of some pathway. Think of a VT pathway. Think of a, I don't know, MI pathway, or sepsis pathway, or DK pathway. You see what I mean? So sometimes there's a no, then we proceed further on the no side. Something the yes, then we proceed to that side. Sometimes it's a no, we stop there. Sometimes yes, we stop there. So understand, but the essential thing is, so we go step by step. So we put in our head a ladder, a cascade. So, conveniently, we label one arm of the ladder or cascade or dichotomy yes, and the other arm we label no. And then in our head, we calculate. Okay, we put, think of some set of like lines or something. So yes, then go there, no, then stop, or the yes, stop, the no, go there. So it's interchangeable. You see what I mean? So here that's the beauty, is it? Because here we are flexible. We are flexible to sort out something which is not flexible. You understand? So we are flexible to think of an operation, appendectomy, which is rigid, because we use flexibility to achieve a goal which is defined. You understand? So it's a funny sort of how our mind work. Okay. Now this process of analytical decision making process is more often used in the condition which need risk stratification. Okay. So we know what condition need risk stratification. For example, thromboembolism. Okay, venous thromboembolism. So here we have a dichotomy as a, so okay, so how we risk stratify? Oh, is a person pregnant? Okay, is a drug user? Is a previous VT? as in cancer treatment. Okay, so this process is normally we used in a risk stratification. Now, again, please don't compartmentalize different options of the decision making, a different type of decision making. Don't compartmentalize, because we are using analytical process in a risk stratification, and then we might be using next step as a pattern recognition, or we might be using rational model. You see what I mean? So it's absolutely interchangeable, so we are interchanging, so we are flexible. Okay, so that's the beauty of a trained clinician. Okay, so basically this model encompass using a series of questions. They might be ending up having no or yes, and then we proceed further. And commonly it is very good in condition which need risk stratification, but all the models are interchangeable. And we have given example of VTE. Similarly, if somebody comes with a cough or something, then again you set up a question. You say, oh, whether it's a contact with a COVID, or whether people are coming with an area where the tuberculosis have a high prevalence, or it might be just a flu virus. You know what I mean? So this is how we use this model of the an analytical thing. Okay. Now, other thing is we also can use this model like young person come with a chest pain or collapse. Okay. Then again, you risk stratify. You say, is there any sudden cardiac death in the family? Okay. So then you proceed further. So you can use these model we always use in a myriad of conditions, and we use it every day and daily. So as I said, the aim of the talk is that we should recognize that these things are there, we are using all the time. Okay. Now, as we start at the beginning, because when we talk about stuff which impact on the people life, then the behavior of the people, personality, cognition is very, very important. Okay. Now here I use this information, not information and relationship, team leader and team member, social focus, skill mixed of the team member. So in that set of decision making process, okay, so all these factors we take into account. Okay. Now as Suraj Prajwal talking about last night experience. Okay. So you do all this stuff, but you were not sure what's happening. But there was something in your head, which we call a gut reaction, that no, there's something wrong with these patients. I don't want to discharge these patients. I want to go a bit further. And you went a bit further, the result was successful. Okay. And, by listening of your story, you are impressing me. You are impressing your colleague, because, you are right there. So that's what we mean, behavior, the social focused. So all these skills are in that sort of stuff that, oh, there must be something wrong there. Okay. For instance, you see a person, I saw a person like, I think he was mid-80s. He was fishing last night, and at the fishing site, he developed what he was saying, a back pain. Okay. And he was in a cubicle 10. We put cubicle 10 people, which not serious really, because it's in the corner. So they put up there. So, I saw him on the computer. I said, no, should I go and see him? So I just went in, and he was in terrible pain. Okay. So I immediately said, no, he's moving about. If it's a back hurting, he would have been still. Okay. So, and the pain is not, back pain is when people are still, they're not bad, So, but he's got terrible pain. So I went out, there was a scan there, I got a scan, and it was about 7.58 centimeter AAA aortic aneurysm. Okay. And this man went into theater within half an hour, record time. Okay. So in my head, there was something, no, oh God, there's something not right here. So it's a cognition, it's a behavior. You understand? So we are using our cognition, behavior, to reach a diagnosis. But of course, this was the beginning. Then of course, my mind diverted to rational decision, pattern recognition. You see what I mean? You can analytical, you can jump everything together now. Okay. So this talk, please don't think this talk is like MI or something which is defined. No, not at all. That's how the beautiful these talks are, non-technical skill. So they are not fixed, they are convertible, they are inclusive, they are flexible. So we use them all the time at different time in different way. Okay, similarly, I went to see a gentleman, he was in cubicle 14, the new cubicle 14, and he was about 65 years old, and he was sitting in a chair. They put him in the chair, but his pain was out of proportion of the abdomen than the symptom and sign. I said, no, there must be something wrong. And I look at the blood, they're all normal. Tummy soft, vital sign 0. I said, God, I must look at something else. So I look for the blood gases, venous gases. So luckily, the venous gases was done. You know what the lactate was about, I don't know, 3.4 or 4 point something. Okay. So I put him on the trolley, give some fluid, morphine, done a CT contrast. It shows mesenteric artery thrombosis. So, so that's what I mean, the behavior process when we reach in the decision-making process. Okay. So any questions so far? Happy?
No.
Should we proceed further? Now we are talking about what biases we encounter, and again the aim of talking about biases is, as I said earlier, that they're very important, that we should acknowledge they exist, because once we acknowledge they exist, they make us a better decision maker. Okay. They compel us not to be fixed, not to be rigid. Okay. Because when we are fixed in our decision, when we are rigid in our decision is almost always no good. Okay. Hence, this part of the talk is very important. So, I mean, we define biases as inclination or prejudice for or against something. The bias is defined as an inclination or a prejudice against or for something. That's how we define, in a dictionary. Okay. So as I said, so we should be aware of that they exist, because being simply aware of they exist make us a better decision maker. So I put here is a confirmation bias, hearsay bias, borrowed ideas and models, using shortcuts, halo effect. So I've used these sort of terminology, in our talk. So what is confirmation bias? So the confirmation bias is, paying attention only to the information and evidence which prove that we are right. You see what I mean? I mean, I don't want to be like that. Not at all. Okay. I mean, God help me. I will be absolutely detesting myself if I'm that. Okay. Again, you see, how important flexibility and the terminology we define, tolerance of ambiguity and social, and the focus, the things are in the decision-making process. Okay, so that's how we define, the confirmation bias. Okay, for instance, I do tell people that please treat your patient, don't treat yourself. Okay, I've done myself. I still do myself. Okay, but the essence is, the more you treat your patient, the better you become the clinician. Okay. So I can explain a bit further what I mean by treat your patient is that, what's the time? Are we okay with the time? Yeah.
You sort of gone 10 past, boss.
Okay. For instance, sometimes people come with a little bit chest pain. Okay. You know what people say? Oh, am I missing a aortic aneurysm? Okay. Should I not do the CTPA? You know what I mean? Because that's my ego. That's my bias. That's I say, no. Oh, why? Just to know what's happening. No, we should not do that. We should treat the patient. So that's the one example of confirmation bias, that we should not confirm ourselves that we are big or whatever. Rather, we should focus on the patient. How to avoid this bias? Okay, please revisit the data. Okay, I always tell people, please talk to each other. No, the first thing I ask people, talk to yourself, talk to your heart, talk to your brain. Am I right? This is the action I'm taking. Am I doing right? Consider all the other factors when you decide. Oh, what will happen to the patient? What will happen to my resources? What will happen to the relative, to friend, to my team when you talk to yourself? So, does this patient need admission? If I admit, what is gaining for admission? If I admit him, what if he got a DVT, a PE, died? What if he got a COVID? What he's got, so all these factors, talk to yourself when we are not sure what to do. Talk to the person next to you. Believe me, it's very important. It might well be anybody really, There's a famous Arabic scholar, I don't know the name, I think Zia might know. He used to talk to his goat, okay? So talk to the person next to you, so that will, and of course, there's other help available. Well, talk to your senior, okay, go to research, whatever, revisit the data, and that's how you avoid this confirmation bias. Here says again, another bias, this we use, on a perception of a reality. Okay, so the reality is perceived. For instance, in medicine, if people are coming with a cough, okay, so if I know carbocysteine will work, which is expectorant, okay, I just prescribe expectorant and let the people go home. You understand? That's what I mean here, say a perception of reality. No, we should not be perceiving reality. Rather, again, we should look deeper, and we know what other model we use to make a decision. So we don't want to stick to one model. Use one model. If that's not fitting into that particular problem, use another model. Okay, so don't go on hearsay. So that's how you come on this bias. Borrowed ideas and models, again, people use in a different way. It's called anchoring bias or something like that as well, by which I mean, if something is working somewhere else, it doesn't mean that will work in my working environment as well. For instance, so we've been to seek a model of integrated elderly care in Hull. So, so they have got a helicopter, they've got everything, they've got a very good, community support. So, so that model might not work in Doncaster, because in Doncaster, community support is bit I don't know what word I should use. So that's what I mean. So if we use borrowed idea, okay, so that model not be suitable for us. So again, be flexible, go to data, go to your local sort of environment, and then decide. So what is good for us? Similarly, using shortcuts and the halo effect, they are almost interchangeable. Okay, it's like a gut reaction, Our shortcuts are normally used when we are busy. Okay, when there's no time, when the other stuffs are going on, then we use shortcuts. Okay, so I can give the shortcuts, lot of examples you can have. I would talk a little bit about halo effect. No, halo effect is the effect which you believe apparent sort of appearance. You believe in appearance. Okay, So no, because this is look that, it might be that. Understand? That's a halo effect. I can give you an example, then probably, we will understand a bit better. Like if a person have a pallor, okay, now I will say, oh no, he's got anemia. And I've prescribed some iron tablets and let him go. But it might well be his normal complexion. It might, he or she might be eating a lot of carrots, carotenemia. And I believe me, I've seen people, gulping a lot of carrots and with a pale color. Okay, it might be jaundiced, Okay, so we need to explore a bit further, So again, to overcome this biases, you give a pause, you sit down, you think of alternative, you use the other model, okay, like different model to come to the conclusion. So don't go on the apparent appearance that if person is a yellow, so it must have a CKD. No, there are other alternatives which can be there, and then we work on it, as we talked about previously. Okay.
Mr. J, how much more have you got?
No, that's it. Finished.
Oh, okay, perfect.
Any question about these? Was it beneficial or just gibberish?
It's very useful.
Okay. No, I finished now. So any question you can ask. But the main thing is being flexible. Remembering that there are biases about the decision making. So, and remembering that we don't use only one decision, we use a lot of different model to make a decision, and it's interchangeable. And also, please remember that there's something decision making process exists in our knowledge and training, and it's very important. Okay, so no, I finish. If there's no question, then I can come out.
Thank you.
How can I come out now? Stop sharing.
Yep.